So I am pleased to update the public on this matter that affects the lives of over 300,000 citizens on the CDAP program. Just to indicate that, of course, since its establishment in 2003, CDAP has served as a vital health equity mechanism, providing free, essential medication for chronic diseases such as hypertension, diabetes, asthma, and more recently, mental health. As of July 2025, CDAP would have covered 11 chronic diseases, offers 52 pharmaceutical items, and operates through over 230 pharmacies, private pharmacies nationwide. Whilst we note CDAP's success, we must also recognize its current challenges, including rising costs, outdated drug regimes, and gaps in diagnostic support. So the clinical landscape has evolved. CDAP has been in existence since 2003, and therefore, so must we. So in line with the government's health reform program, as the Minister of Health, I commissioned a CDAP Review Committee on June 5, 2025, with a mandate to assess the program's clinical, operational, and financial performance. This committee, comprised of senior health policy and clinical experts, was tasked with aligning CDAP with modern clinical practice and ensuring its long-term sustainability. So yes, CDAP is here to stay. Their findings are clear. While CDAP remains a crucial public good, its drug list must be updated, its diagnostics strengthened, and its structure modernized to reflect today's medical realities. So, out of this review, allow me to highlight 5 key outcomes. The first is the rationalization of the drug list. So what the committee would have recommended is that outdated and clinically inferior medications are being replaced in some categories, and I can give you a couple of examples here. So for example, in the area of mental health, the drug sulpiridide is now being replaced by a drug by the name of risperidone, which is a more effective antipsychotic agent. In the area of cardiovascular disease, which is a common disease and condition, the drug simvastatin is now being replaced by a drug by the name of rosuvastatin. It's commonly called Crestor. So Crestor will now replace simvastatin, and this has been because it provides superior cardiovascular protection in terms of a lipid lowering drug. At the same time, in addition to the replacement of current drugs on the CDAP program, the recommendation from the committee was to introduce at this time additional medications. In this instance, it's 2 medications, and the cabinet has accepted that recommendation, which will be to add a drug called clopidogrel, 75 milligram. The common name is Plavix, and a drug called losartan. The common name is Coza, 50 milligram. These additions to CDAP are new, and of course they will offer protection in the area of cardiovascular disease. As some of you may know, the public will know, Plavix is a drug that thins the blood, and of course losartan is an antihypertensive. And these recommendations have been made based on clinical guidelines from the WHO and the United Kingdom's National Institute of Clinical Excellence. So that will be the rationalization of the drug list. The other issue, of course, will be the financial efficiency and the cost savings. So these, although we are intent on making changes, we are also looking at the cost effectiveness of these changes. And therefore, we anticipate that the total savings of over $4 million will be saved over the cycle of one CDAP cycle. And this will be driven primarily by smarter drug selection and diagnostic procurement, and I'll come to that matter in a minute. The most significant saving, almost 70%, will come from replacing the current blood glucose monitoring system. How does government intend to do that? So currently, glucose strips cost the government approximately $1.15 per unit. Through a proposed government-to-government arrangement with the Republic of India, you'll recall the recent visit of Prime Minister Modi, at which an MOU was signed and would have included the ability of the government to access drugs from India, same high-quality drugs, but at a cheaper cost. So we have found that we can replace these strips that currently cost the government $1.15 And now we can acquire ISO certified, WHO pre-qualified strips at less than 34 cents per unit, delivering much better value. So I just want to make the point here, because the question will be asked, of course, when the cost is reduced, whether the same quality is being offered to the public, and I want to give the assurance that the answer to that is yes. I also want to announce that coming out of this committee, there is a recommendation for something called CDAP Plus Initiative, and this is in recognition of the need for advanced treatments that is not covered under the current program. The ministry will develop a new initiative, and this will allow access to specialist prescribed medications, again delivered through private pharmacies, under regulated pricing agreements and at no direct cost to the government. The details of that program are yet to be ruled out. The committee is still working on this, and a full implementation proposal is expected to be brought to the cabinet by the end of the year. What are the other benefits of what has been done and recommended by the committee? We want to also look at enhanced rural access. Access to medication should not be determined by postcode. In this regard, we are removing the $68,000 technology entry costs previously required of pharmacies to join CDAP. In 2018, the previous government had made a cabinet decision to charge new pharmacies wishing to engage in CDAP a cost of $68,000 to get into the program. The cabinet has accepted a recommendation to remove that $68,000 cost, and what is going to happen going forward is that pharmacies will now be permitted to self-source the IT equipment, which will be in line with ministry specifications, whilst the ministry provides software support. In reality, this cost for new pharmacies wanting to enter the CDAP program will be reduced from a charge of $68,000 to a figure that will be much, much less, because it is just the cost of the IT equipment, which, as we know, is now much cheaper. We're also looking at the area of strengthened diagnostics. Beyond the medications, CDAP's diagnostic capabilities will also be enhanced through international cooperation, particularly with India. We aim to reduce costs and expand access to glucose testing, which is a critical need amongst our diabetic population. Additionally, we will work with private pharmacies to improve reporting, tracking, and inventory management, reducing wastage and improving patient outcomes. We have found that because of poor inventory management, that there is an issue of wastage and of drugs and so on, and of course at a cost to the taxpayer. So taken together, these reforms represent a shift from a drug distribution model to a patient outcome-driven platform, a model that is clinically current, cost-conscious, and operationally efficient. So we are not dismantling CDAP, far from that. We are strengthening it with better medicine, greater access, and better outcomes for the people of Trinidad and Tobago. So I want to close by thanking the members of the CDAP Review Committee for their thorough and thoughtful work, and I recommit this government to the principles of universal health coverage, health equity, and sustainable reform. I am confident that the Chronic Disease Assistance Program is entering a new era, one that reflects the realities of modern medicine, the needs of our people, and the stewardship of public resources. I thank you, and I remain open to your questions.